On August 1st, 2018, the Southern Nevada Health District released brand new protocols for all EMS providers. The first protocol that we're going to review is going to be the Acute Coronary Syndrome Protocol. The Acute Coronary Syndrome Protocol has actually been now broken up into two separate protocols. You now have the chest pain, non-traumatic, and suspected acute coronary syndrome protocol and the STEMI protocol. For the chest pain, non-traumatic, and suspected acute coronary syndrome protocol, we start off with a general patient assessment. Paramedics are immediately prompted to do a 12-lead ECG within 5 minutes of patient contact, and if the ECG is a STEMI, we are then shunted to the STEMI protocol. However, if it's a non-diagnostic 12-lead ECG, then AEMTs get vascular access. EMTs provide oxygen as long as the SpO2 is above 94%. EMTs can give 324 milligrams of aspirin. EMTs can assist patients with their own nitroglycerin up to 3 times. Paramedics can do nitroglycerin 0.4 milligrams sublingual every 5 minutes for 3 times. Paramedics can also continue with pain management protocol, and paramedics can consider Zofran or droperidol for nausea and vomiting. And the patient will then be transported to a hospital of their choice. In the STEMI protocol, we start with a general patient assessment, and it directs us to get an EKG within 5 minutes of patient contact. After we recognize that there is a STEMI, we are going to immediately notify the receiving facility of the recognition of a STEMI. AEMTs are going to obtain vascular access. EMTs can provide oxygen. EMTs can provide aspirin at 324 milligrams PO, and then we are then directed to give nitroglycerin. EMTs can assist with the patient's own nitroglycerin, whereas paramedics can give 0.4 milligrams sublingual and may be repeated every 5 minutes 3 times. Paramedics are going to continue with pain management, and paramedics can also go ahead and give Zofran or droperidol for nausea and vomiting, and the patient is going to be transported to an appropriate receiving facility. We see that nitroglycerin is contraindicated in any patient with hypotension, bradycardia, and tachycardia in the absence of heart failure, evidence of right ventricular infarction, and use of erectile dysfunction meds within the last 48 hours. This is a change to the new protocol, is that all erectile dysfunction meds are 48 hours. Caution is advised in patients with inferior wall STEMI, and right-sided ECG should be performed to evaluate a right ventricular infarction. In the allergic reaction protocol, the big change is that paramedics can now give a push dose of epinephrine. This is a diluted down dose of epinephrine of 1 to 100,000. The dose for push dose epinephrine is going to be 5 to 10 micrograms IV and may be repeated every 2 to 5 minutes to maintain a systolic blood pressure greater than 90. Or paramedics can also go ahead and consider dopamine at 5 to 20 micrograms per kilogram per minute, titrate to keep a systolic blood pressure of more than 90. So for push dose epinephrine, we're going to use cardiac epinephrine. We're going to use our brown box epinephrine. So we're going to take it out of the box. We're going to take our syringe, put it together, and we are going to squirt out 9 cc's of fluid. Once you have your cardiac epi drawn up, so you have 1 cc of fluid left over in the syringe, then you're going to want to go ahead and draw up 9 additional cc's of normal saline. The best way that I found to do this is to take the largest jumper needle that you carry on the ambulance and attach it to the end of the pre-filled syringe. You're going to take the cap off, and now you're going to withdraw 9 cc's of normal saline from a bag of normal saline. Now you've got 10 cc's of fluid in your syringe. You have 0.1 milligram in 10 cc's, and now you can go forward with giving your cardiac dose of epinephrine. In the cardiac arrest, non-traumatic adult continuous cardiac compressions, the rate has been changed to meet AHA standards of 100 to 120 compressions per minute. The same applies to pediatric cardiac arrest victims. In the childbirth and labor protocol, the positioning for a patient with a cord presentation has been changed from a knee to chest position to Trendelenburg position with the patient slightly on the left side. In addition, a pearl was added to confirm that via telemetry to determine whether the mother and child will be seen in the ER or go to labor and delivery. In the general adult assessment protocol, it was clarified that a patient may be placed in the waiting room if they have received a single dose of analgesia or antiemetic medication only. A new protocol to the August 1st, 2018 protocol update is going to be the addition of an Epistaxis protocol. In the Epistaxis protocol, we evaluate the patient to see if they have active bleeding from the nose. If the answer is yes, we assess for significant or multi-system trauma. And if the answer is no, we then compress the nose with direct pressure and tilt the head forward in a position of comfort. If the answer is yes, we are then shunted to the general adult assessment trauma protocol. If the patient is not actively bleeding from the nose, we are then directed to assess for active bleeding in the posterior oropharynx. If the answer is yes, we do direct pressure on the nose. If bleeding is not controlled, we are directed to have the patient blow their nose to suction active bleeding. In addition, a new medication is Afrin, and we are directed to give 2 sprays of aspirin up each nostril, followed by direct pressure, and we continue the general adult assessment. Afrin, or oxymetazoline, is a new medication that is allowed in the new 2018 protocols. In addition to the Epistaxis protocol, we have pearls that have been added as well. We see that it directs us to assess the patient for blood thinners, such as Coumadin, Lovenox, Predixa, or Xarelto, and to assess for patients that might be taking antiplatelet agents like aspirin, Plavix, or Agranox. In the hyperkalemia protocol, it specified that patients must have suspected hyperkalemia or electrographic findings consistent with hyperkalemia, which would be bradycardia with widening QRS, before initiating treatment. On the screen, we see an example of what might be EKG changes consistent with hyperkalemia. This may include a wide, flat P wave, prolonged PR interval, decreased R wave amplitude, a widening QRS, a tall PT wave, or a depressed ST segment. And we see here we have a 12-lead EKG example of hyperkalemia before administering calcium. The hyperthermia and environmental illness protocol has been renamed to the heat-related illness protocol. And the heat-related illness protocol calls out active cooling measures to include cold packs, ice, fanning, and air conditioning. In the pearls, for the heat-related illness protocol, cold saline is not to be administered for the treatment of hyperthermia unless directed by a telemetry physician. The hypothermia and environmental illness protocol has been changed to the cold-related illness protocol. In the obstetrical emergencies protocol, we have added on pearls to show that postpartum eclampsia and preeclampsia commonly presents up to 48 hours after childbirth, and if symptomatic, to treat as eclampsia and preeclampsia. In addition, preeclampsia and eclampsia can present up to 6 weeks after childbirth, and to assess the patient for history of preeclampsia and eclampsia during pregnancy or delivery. In the overdose poisoning protocol, EMTs are now directed to give naloxone intranasally 2 to 4 milligrams, and IM ketamine has been added on as a route for ketamine administration. Intranasal naloxone is a new skill for EMTs. This is Narcan that is given up the nose. In order to give Narcan up the nose, EMTs are going to, first of all, take the medication, and on top of the medication and the pre-filled syringe, there is a cap. You can take the cap off, then screw together the medication into the pre-filled syringe. In order to give naloxone intranasally, you need to make sure that you have a mucosal automator device. The mucosal automator device, or MAD, attaches onto the pre-filled syringe. When giving Narcan up the nose, only 1 cc of fluid per nostril is allowed. You're going to gently squeeze the medication until it mystifies, and you're going to give half a dose up each nostril. In the pulmonary edema CHF protocol, nitroglycerin is now contraindicated for any patient using erectile dysfunction medications in the last 48 hours. And in the seizure protocol, IO has now been added as a route for midazolam and diazepam administration. In addition to the seizure protocol, it now directs us that if the patient is pregnant and seizing, we are now directed to the obstetrical emergencies protocol. In the shock protocol, we now have the ability to give either a push dose epinephrine, or we can consider dopamine at 5 to 20 micrograms per kilogram per minute. In the pearl section of the shock protocol, an end-tidal CO2 measurement of 25 millimeters of mercury is indicative of shock. In the stroke protocol, we want to document the last time the patient was normal with a phone number for the witness. The protocol then directs us to perform and document the race stroke scale. After we perform the race scale, we're then prompted to assess whether or not there's a large vessel occlusion based on the race score. If the answer is no, that means there's a race scale of 1 to 4, and the patient can be transported to an approved stroke center. If the answer is yes on the race scale with a score of more than 5, We want to have a scene time of less than 5 minutes, and we want to transport the patient to a NIR-capable facility. We see on the screen an example of the race scale that has also been included into the protocols. Now on to pediatric specific protocols. In the allergic reaction protocol, we now have the ability to give a push dose of epinephrine, and the push dose epinephrine is 1 microgram per kilogram. The hyperthermia and environmental illness protocol has been changed to heat-related illness protocol, and we see that we are now directed to give active cooling measures similarly to the adult protocol. In addition, for kids, cold saline is not to be administered for the treatment of hyperthermia unless directed by a telemetry physician. The hypothermia and environmental illness protocol has been changed to the cold-related illness protocol. We now have a pediatric Epistaxis protocol, which is very similar to the adult Epistaxis protocol. The key difference is that it's going to ask us if the patient can tolerate having the nasal spray. If the patient can tolerate having the nasal spray, have the patient blow their nose out, and then go ahead and continue with the Afrin administration. In the pediatric overdose poisoning protocol, EMTs are directed to give naloxone if it's a suspected opiate overdose. In the pediatric pain management protocol, morphine and fentanyl have been separated to show that those medications are not to be given together. In the pediatric shock protocol, patients are to be given a push dose of epinephrine. There is now a pediatric smoke inhalation protocol, and in the protocol itself, there is exact instructions for giving pediatric weight-based hydroxycobalamin. Moving on to the operations protocols. In the communications protocol, we have added wording to notify or meet with a receiving facility prior to transfer of care with suspected need for contact isolation preparation. In the documentation section, there has now been added that all monitor files must be uploaded and attached to the PCR if the monitor was used for any of the following purposes. This includes assessing or monitoring the cardiac rhythm, obtaining a 12-lead EKG, providing electrical therapy, such as cardioversion, defibrillation, or pacing, and monitoring end-tidal CO2 levels on an intubated patient. In the public intoxication protocol, it has been added that we have to get approval of the physician or medical staff upon assessment prior to transport to an alternative facility. In addition, that contact must be made through a recorded phone line through the FAO using the 702-382-9007 phone number. In the transport destinations protocol, patients who want to go to a remote outpatient emergency room, we have raised the diastolic blood pressure to a maximum of 110 millimeters of mercury. In the trauma destinations protocol, step 4 has been changed to assess for special patients, and we have added in that the patient must be transported to a level 1, 2, or 3 trauma center for the treatment of trauma in accordance with the catchment area designated. For patients who are injured outside a 50-mile radius from a trauma center, the licensee providing emergency medical care shall call and consider transport to the nearest receiving facility. In the waiting room criteria, the diastolic blood pressure has been raised to 110 millimeters of mercury. Moving on to the procedural protocols, electrical therapy, synchronized cardioversion, and transcutaneous pacing now have the same adjunctive therapy. For adjunctive therapy, we can go ahead and consider sedation. That's going to be etomidate, midazolam, or diazepam. For etomidate, we give 0.15 milligrams per kilogram. For midazolam, we give 0.1 milligram per kilogram, which may be repeated every 5 minutes at 0.05 milligrams per kilogram. And for diazepam, we give 5 milligrams IV, which may be repeated after 5 minutes with a physician order. For analgesia, we can give morphine sulfate, 0.1 milligram per kilogram, slow IV push to a maximum single dose of 10 milligrams, and may be repeated every 10 minutes until pain is relieved or respiratory or mental status depression occurs. Fentanyl can be given 1 microgram per kilogram, IN, IM, or IV to a single max dose of 100 micrograms, and may be repeated every 10 minutes without physician order. We can also give hydromorphone up to 1 milligram IV and may be repeated after 10 minutes with physician order, or we can go ahead and also give ketamine at 0.2 milligrams per kilogram IM, IV, IN, IO with no repeat dose. In the traction splint protocol, we added an indication that this procedure may be performed on any patient with isolated mid-shaft femur fracture. And in the key procedural considerations, we specifically call out to exercise care when applying traction to not reintroduce bone ends into the body. In the vascular access protocol, the contraindications for intraosseous infusion are now similar to what is recommended by the manufacturer. The contraindications include placement in or distal to a fractured bone, previous significant orthopedic procedure at the site, or prosthetic limb or joint, or IO catheter use in the past 48 hours of the target bone, infection at the area of insertion, or excessive tissue such as severe obesity and or the absence of adequate anatomical landmarks. In the formulary, activated charcoal has been removed as a medication and it is no longer carried on the ambulances. In addition, Afrin has been added as a medication for patients with nosebleeds. This brings us to the end of the 2018 protocol updates from the Southern Nevada Health District.